How can it help your patients? Without a doubt, DBS is the most effective with tremor, which is actually interesting because tremor is the most refractory symptom to medication therapy with Parkinson's patients. And so that's a nice kind of niche thing. It's also helpful for bradykinesia with Parkinson's patients with rigidity. It's really good for motor fluctuations. As we talked about, it helps with that off time. That continuous stimulation for patients is so nice instead of these peaks and valleys that you get with levodopa therapy. Aside from off time and on time, the levodopa therapy patients will tell you they feel this crash sensation. And I'll say DBS will often help with that crash feeling in my patients, but there's something about that continuous stimulation that really helps with that off and on and those motor fluctuations. It can also be very useful for dyskinesia with your patients, depending on where you're stimulating. For essential tremor, 60 to 90% of patients report a reduction in their tremor, and a lot of essential tremor patients can get off of their medications. So when to consider DBS for your Parkinson's patients? This is where I think being a general neurologist, utilizing DBS is the most critical. The problem is, by the time the patients are getting down to see a movement disorder specialist, they're kind of out of that window where they're going to get the maximum benefit anyway because they're too advanced. DBS is not first-line therapy, but here's when I think about DBS. Number one, patients who are starting to require high doses of levodopa therapy. We know that over 600 milligrams of levodopa therapy a day increases the risk for dyskinesia significantly. So when I start to see that they're ramping up their levodopa dosages and getting closer or over that 600, that for me is a patient who I'm thinking about DBS. Anytime they're having significant side effects to the levodopa, but they're levodopa responsive. So you have patients who the levodopa therapy helps them a lot, but it causes a lot of orthostatic hypotension, or it makes them really nauseated, and so it limits your ability to use it. Those are great DBS candidates because you really want to be levodopa responsive before you get DBS. Those are the patients who are going to do the best with DBS. Also for patients who have a lot of off and on and those motor fluctuations, that smoothing of continuous stimulation, there's something about just continuously stimulating that movement center of your brain that really is good, I think, for long-term treatment in Parkinson's patients. Those are really good candidates for DBS. Who is not a good candidate for a DBS? Somebody with a lot of cognitive impairment, because it can certainly worsen that. Somebody who's advanced, and then patients who have contraindications for surgery. As a general neurologist, this is something that you should consider, in my opinion, as part of your treatment options in your patients with Parkinson's, because treating early has shown that these patients have slower progression of tremor and have long-term benefit. When are you going to think about it for essential tremor? Medication options are limited with essential tremor. We know that DBS is very effective for tremor. So anytime you're getting a lot of side effects from medications, you're having to ramp up the dosages of medications in order for the patients to have any control of their tremor, these are the people who you want to consider for DBS. Once I get a good program for these patients, they can kind of hold with the same program for a long time. I tend to refer a little bit earlier for essential tremor even.